Okay, so Tony, such an extraordinary delight to have you. We've already had a few minutes with you on Popsicle Patrol. I love that you just helped us figure out the one popsicle per hour for one
Yes.
of our coworkers' kids. Is as a doctor, you're equipped to be giving us advice like that. So thank
That's
you.
right.
So,
That's right.
right? We have to
That's
listen to that.
right.
So formally, you are a professor of medicine in the Division of Medical Oncology at the University of Washington, or I understand that if I were cool, I would call it UWash, so I'll call it UWash. You're also co-director for the Cambia Palliative Care Center of Excellence. Huge shout out to the extraordinary work of Peggy McGuire and Mark Gans, love, 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 and the
Yeah.
rest of that whole team. They're incredible. You are the co-founder of Vital Talk, which is a nonprofit that is scaling communication training to clinicians using a social entrepreneurship approach. As an entrepreneur, I appreciate that. I would add you are really obsessed with improving patient-physician communication, and your work to that end has been funded by the National Cancer Institute, by the Robert Wood Johnson Foundation, by the Gordon and Betty Moore Foundation, by the Arnold P. Gold Foundation, and the list actually really goes on. So you were educated at Stanford University and Harvard Medical School, and you were a faculty scholar for the Project on Death in America, which I think is so funny because to me that just sounds so cool. Like, wow, that's cocktail conversation. I can't wait to talk to you all day long. I think probably about 2 months ago, a lot of people would have thought that was weird and not appropriate conversation. I think that's changing in the US. I think that's changing for hard reasons, but it's changing for good. Your talent is widely recognized. Your awards include, and I had to cut this off, but include the Pathfinder in Palliative Care Award from the American Cancer Society, the National Leadership Award from the American Academy of Hospice and Palliative Medicine, and the Walter Cancer Foundation Palliative and Supportive Care and Oncology Endowed Award and Lecture. In my house, we'd be like, damn, that just means you are a rock star, and we are incredibly impressed, all of us bowing to you. So when we were prepping, it was so fun to have a chance to be thinking with you on this in advance. I gave you a choice. I said, I'd love to start with you either telling us something raw and different and unorthodox, or you can just share how you got into this. And you chose, I'd like to share how I got into this. But in the end, you actually really gave me an overview of both. So I'm going to ask you formally, how did you get into this? But you know what I'm really curious about.
Yeah. So I got into this line of work, which is a little bit off the beaten track for oncologists, because my mother died when I was in college. So I was a sophomore at Stanford. I was trying to figure out what to do with my life. And she had had a blood cancer that had been kind of chronic, that had been going on for a while, and then had a really sudden decline. Fell and ruptured her spleen and ended up in the hospital. And in those days, of course, they called you on the phone, like the dorm phone, like that's how I found out. And my father, I remember, so didn't know what to say. He said, the doctor's here to talk to you. And he put the oncologist on the phone. Yeah. And the oncologist started to talk about her spleen. And I was like, yeah, the spleen. What does that mean? And at the end of the call, I was like, I don't really know what this means, but what I know is I need to call the travel agent and get a plane ticket and get on a plane. And so that's what I did. It was finals week. And that was a big wake-up call for me. I had had a very, secure kind of childhood. And that was like, wow, now I am going to figure out how to live on my own, because I think in retrospect, I was looking for kind of what's the wisdom that you need when you grow up, right? And so I started to take some different classes that I had ever taken before, the humanities and the classics. And in that, I stumbled on the work of the novelist James Joyce and Virginia Woolf. And of course, what they emphasize is the richness of everyday people having an everyday moment, right? And that is really something that has stuck with me to that day. And it's where I learned to really pay close attention to what people said and what they were thinking about. And it really laid the stage for my work later.
So yeah, I love that you talked about paying attention to the inner voice, and that really being a genesis of your enormous interest in dialogue. And I'm
Yeah,
sorry, it's hard to hear stories like that. So about your mom and finding out that way, and I think so many are experiencing different versions of that right now. So
absolutely.
you went to med school, and you said one of the things that really was impressed upon you was how thin was the word you used, and I love that.
Yeah.
how thin was how doctors talked to patients, and
Yes.
how much that contrasted with the depth and richness of these issues that you had, these humanity issues, the existential issues about life and values that you've been studying. And you said how it's the everyday moment, not the huge Hollywood moments. It's the magic and mystery of honor of these everyday moments that really most fascinated with you. And you felt that that contrasted so much with what you saw at med school. Say a little bit more about that.
Yeah, so I remember one of my first things in med school, first encounters of this was with a really famous oncologist, and I was following that person on rounds as a medical student, and we were in the emergency room, supposed to see a patient who had been staying there overnight because there was no bed, and the attending physician said to the fellow, the person above me, you know, how's Mrs. So-and-so doing? And the fellow said, oh, she died. And the doctor, the attending physician said, well, she was an old trout. And I was like, what the heck is that? She's an old, what does that mean? And so no one else said a word. He turned the corner to go into a different part of the emergency room. We all followed him like a school of fish. And I was like, oh my gosh, what is this? And we never said another word about it. Like, and this was actually an adorable kind of grandmother person that we had spent like half an hour talking to the day before. I was like, oh my God, this is how we recognize this. It was
Well,
crazy. Yeah.
and one of the things that, so I'll ask you the follow-up question, which is, and would that would leave us with an impression that this physician wasn't very warm, that
That's
there
right.
was sort of a lack of caring amongst you as a team.
Right, right. And the reality was he was a very warm person. He was very nurturing of young physicians like me, and obviously a caring person. But when it came to what you were saying with what he said with the patients, I was like, wow, that is really different. And it wasn't until years later that I realized, you know, talking to anthropologists and reading more research, that is how that is how doctors talk to patients. That what they say in the conference rooms or in the hallway is different than what they say to them in real life.
Mm.
And you know, then you combine that now with this all this research showing that, you know, patients don't always make the decisions that you think they'd want to make if we really knew what they cared about. And it's because I think oftentimes they don't get the communication that enables them to really understand what they're up against.
Yeah.
Right.
Well, and it's clear because we know so many physicians who are in these roles. That's not who they are in their soul, right?
Exactly.
It's
They
the
went into
fact.
medicine. They
Yeah,
go into medicine with all these ideals about how to reach people, and
we
it
love
kind
and
of
to
gets
care.
trained out of them,
Yeah.
right?
So you talked about the work of Rachel Remen. Am I
Yes,
pronouncing it correctly? Remen.
yes.
And it reminded me of something that Frank Ostaseski said at Endwell this past year about his very personal experience with the healthcare system as he recovered from a stroke, as he is recovering from a stroke, and how people keep asking him, how's your recovery? How's your recovery? And he said this beautiful thing that I can't get out of my head, that he says to folks, it's not my recovery, it's my discovery. Because
Mm,
recovery implies you have to go back, and discovery
right.
implies you are somebody new, but you're no less beautiful, and this is a magical next moment. And I just think about that all the time. It's such a beautiful way to think about something really hard that has happened. And it's
Yes.
not going to go back to what you were, but finding joy or at least a silver lining in where you are now. And I was struck with your story about what it was like to be a young gay man who was not out yet as the AIDS epidemic began,
Yep.
and how you juxtapose that experience and that moment in your training and your growing up to this moment that we're in right now.
Yes. Yes. So what I remember from those days, and this was like the year I was in medical school when the first medical report of AIDS came out, and like now, there was this tremendous feeling of personal vulnerability among doctors and nurses and people who worked in hospitals because nobody knew how it was transmitted for a long time. People were worried about being infected and worried about their personal exposure, and I think it gave doctors and nurses a sense of vulnerability, and it, the media now is talking about how it pierces their sense of invincibility, right? You see that a lot, and I think there is something to that, because if all you've ever learned as a doctor or nurse is that you have to put up this force field shield and keep yourself at a certain distance so that you can do your work because that's the way you do it, that it turns out that's kind of a brittle way to go into your practice. And what Frank is saying that I think is so wise, which is something that it took me years to learn taking care of patients, is that what we need to do is actually help people who are living with an illness find the way forward to the new version of themselves, and stop promising them that it's all going to be exactly the same. Because when I had patients with cancer that I'm taking care of, even when they are cured by my standards, none of them say I'm exactly the same. They say, like, wow, this is a whole new chapter for me. And I think we have to honor that and set that up instead of trying to pretend that we're going to restore people to exactly the way they are. When you've gone through an experience like cancer or an experience like COVID, patient or caregiver, you're not going to be the same. And we shouldn't, right? That we should expect that.
Yeah, well, and it's interesting. I love the different terms, like the things that make you strong make you weak. And I, having had brain surgery myself a couple of years ago, I absolutely love my life better since. And I loved my life once I was diagnosed, which was 6 years before that. And I knew at one point I'd have to have the surgery because I had this greater intensity. I was already overly intense, but now even more ferocious. And I think one of the beautiful things that's bonding us as a country is we're all facing mortality on some level. And that does make you more intentional, and it makes you more present in the moment and more grateful for the moment. And it's interesting because earlier you said that as a med student, you were struck with how impersonal the doctor's conversations would be with somebody who was dying, and that you wanted to change that by celebrating and teaching really the art of conversation. And I asked you, what was the most unexpected aspect of COVID for you? What is the most unexpected aspect? And you said so beautifully, it's less unexpected and it's more profound. And it's about this realization it's bringing to doctors about the role of family and the import of the family through all of this. Say more about that.
Yes. And so, I think what I hear over and over from doctors in New York and Seattle and other parts of the country is that they feel so struck now by what happens when family cannot be in the room with a patient, or the family are at a distance, or they're talking to families on Zoom or whatever like that. I mean, one of my colleagues described it as the heartbreak of not being able to be present. And I think what it has really helped us all understand in this new deep way is what that means for a family member to be at the bedside, to be part of the care team, to be helping the patient feel and speak for themselves. I mean, it's something that we so often overlook or take for granted, and it turns out it's profoundly important, right? I think that's what we're learning.
Well, and you shared a particularly, for me, breathtaking story about a doctor friend of yours who'd never had a person die by themselves before. Or then you corrected and said it's not that they had never died by themselves, but they'd never been a doctor when there had been no family member present.
Yes.
And you told me the story of him sitting by the bedside. Will you share that with me?
Yeah, so this is a colleague of mine, a wonderful physician who was with a woman who's dying of COVID in an ICU. Her husband was at home on the phone, and they knew that this was going to be the last conversation, right? And so my friend sat next to the patient, held the phone up to the woman's face, and helped her husband through a conversation about, here we are, all the things that you might want to say. This is your chance. I love you, I forgive you, you forgive me, goodbye, all those kinds of things. And he said he felt like he was being a conduit for the conversation in a way that he had never been before. He's been in other rooms where he was one of the people over on the side watching this conversation, but he had never been facilitating the conversation. And he said, he could see that the woman's eyes were full of tears, even though she couldn't speak. So he mentioned that to the husband on the phone who couldn't see that, and it was a way of being kind of eyes and ears, and really an intimate part of that conversation. And the value of that kind of conversation for the family member who can't be there, like, that is immeasurable, right? Like, that is what everybody needs
Yeah. Oh,
at those moments.
so such a hard and such a beautiful, beautiful story. And that really is what this tool that you've been building, this resource that you've been building, Vital Talk, is all about.
That's
And in
right.
a way, it's so hard that a moment like this in our history is what's making the need for these skills so obvious. But in fact, it is. How do you help teach someone about something so important? How does Vital Talk do that?
Yeah, so the way we do it, and this is what we've learned over the years of research, is you start with how things are happening now, and what the pain points are for the doctors, right? Like, what do they see now? What they see now is that patients don't understand, they don't make the decisions they think they should be making, right? And they feel frustrated about it, and they feel like unsatisfied at the end of the day. And so then you go to them and say, there's a way that your patients could be better informed, better and more engaged with you, and you could feel better about what you've done at the end of the day, right? That's kind of the ticket in. And then what you teach them is, well, here's actually a really good way to do it, and here's some pieces of that you could take right now into your own practice, and they're little discrete pieces that you can add to your repertoire one by one. So it's like you are building a toolbox of things. And so it's kind of a mechanical, it's kind of a tool-based analogy, but it makes a lot of sense to doctors who are used to clinical tools, diagnostic tools, looking at what's wrong and trying to fix it. And they can apply the same approach to themselves in the way they interact.
Well, it's so funny. It's a language and a process with which they are familiar, but
Yeah.
it helps guide them back to what you said before, why they originally got into medicine in the first place, which was to
Yes.
love on others, to heal, to help, to
Yeah.
care. So your tools are primarily for clinicians, but what about for me, like as a daughter, as a partner, friend?
All the tools that we have learned through research that work for doctors, they also work for family, daughters, mothers, sisters. It's all the same principles.
Yeah.
Um, and a couple of those principles that I think are a little counterintuitive are, one is that the emotion is more important to pay attention to than the information. It sounds kind of crazy, right? You think, well, the emotion is just getting in the way. That's what all the doctors think. But actually, emotion is how we understand and process things, right? Like, it's all of us, and it happens in an involuntary way. When emotion hits us, it actually hits us faster than our thinking brains, right? So that's why the emotion hits you first. And once it hits you, you can't stop it, right? And so it turns out that being able to react to that and be sensitive to that is the thing that helps patients take in more information and understand better. So the counterintuitive part is you need to pay attention to the emotion first and acknowledge it, and then figure out when it's time to weave in the information. So
And
that's
that
one.
process in and of itself becomes self-fulfilling because it feels so good when you do it that it becomes addictive on some level.
Absolutely.
There's until we can get these conversations happening more regularly, we are in a harder spot as a civilization.
Yes.
And you hear, as it relates to COVID, and you hear a lot in the media right now about the terrible things that are happening, about
Yeah,
rationing, about
I know.
you won't get a ventilator, about exhausted doctors. And part of me was thinking, well, the good part of that is now folks will hear why they want to have these conversations with each other way ahead of time about their preferences and their wishes. And I suggested that to you, and you very lovingly, because you're always very loving, said, let me share with you some research that we've done that says kind of the exact opposite. Can you share that?
Yeah, so what the research shows is that you have to explain to people how doing something is going to benefit them, right? you can't scare them into doing something. Trying to scare a mom into having a tough conversation with her kids about this is what I want if I got COVID. Like what we have to lead with is, here's what'll happen if you have that conversation. You'll get the care you want. You'll have some peace of mind. They'll be thanking you later because they'll be thinking, oh, I know exactly what she wants and I can do that. Right? Like we need to lead with that instead of saying, wow, if you don't have this conversation, you're going to end up on a machine and it's going to be awful and they're going to break all your ribs. And that, we've been doing that for a couple of decades, it turns out. But it we've also learned that people just recoil from that, right? No one wants to visualize how all their ribs are going to be broken at the moment of their death. I mean, if you step back and think about it, you think, what are we trying to do there, right? What we need to do is strengthen all the bonds that will help them find the way to, to get their words to us, even if they're not there.
Well, and it's interesting because every other industry has learned early on that it's about aspiration and celebrating it does work. And we suck at that in healthcare,
I know.
right?
It's
And
totally it. That's totally it. Yeah.
it's awful. And you talk, it's like marketing 101. So
Totally.
one of the things that strikes me about this is even when they go well, the perception is that these are hard conversations to have. But one of the
Yeah.
things that I learned in all the years that we've been working in the space and our work with Engage with Grace and now with Archangels is actually once you get the conversation started, they're really beautiful conversations. You brought up another component, which is that having this conversation is a gift, not just for the family, but also for the clinicians. What did you mean by that? And how is that changing because of COVID?
Yes. So what I mean by a gift is that if you recognize the beauty in the deep truth when people talk to you in a straightforward way about this, when you as a doctor or nurse make it safe for somebody else to tell you what they really think, or you as a family member make it safe, people are really sensitive to that and they will tell you what's really in their minds and in their hearts. And, it can be emotional. And the important thing is not to feel like the emotion means that things are going wrong. Actually, the emotion means that you've tapped into something really profound and really valuable. And we have to recalibrate ourselves to recognize that moment. So that's what I mean by the gift.
Well, and we're in a moment right now where there are families that are having this gift and there are families that are not having
Yeah.
this gift. What do you worry about for those who are not having access to that?
Yeah, what I worry about is that if they enter the medical, that they're living with a certain level of fear, and they're spending a lot of their energy kind of pushing that away, because that's what the psychological research shows, that when you try to suppress thoughts, actually preconsciously you're spending a lot of psychological energy doing that, and it exhausts you. So that's one thing. And then the other thing is that if you're not having these conversations and you do end up in the healthcare system, it will feel bewildering and confusing, and it'll go so fast that you feel like you'll never get your bearings. So patients say to me sometimes, well, I'll decide that when I have to. And what I say now is, what, if it's at that moment you have to, that's a really high stakes moment and it's hard to think straight. So if you can think about even a little bit of it now, can you think about a little of it? That will really help you later. And I think part of our job is we have to make it easy for them to do a little bit, right? And celebrate that, and not go, no, you got to keep thinking about this. You have to keep thinking about
Little
this.
steps, right? Little
It's the
steps.
baby steps.
Well,
All we need is a baby step.
it's a baby step. Just get started, and then it gets easier and easier from there. You also talked about how for a lot of families with whom you work or individuals that in retrospect, and this is when the conversation does happen, they say, I really hadn't realized how important this was. And they then talk about being able to pass that gift on to their kids and to their family. And this
Yes.
notion of, oh my gosh, I really can have this time. And it's something that I will remember, and I will look forward to the next generations, this legacy of that we gave each other this gift of having this conversation.
Yes.
So let's pretend for a second that I'm an employer that has 10,000 employees who are working for me. what would you want me to know about what you've been working so hard to get out to clinicians and by extension, the patients and families of those they treat?
Yeah. What I would want you as an employer to know is that you as the employer could say to the health plans that you are, attracting for your employees, that their health plans ought to cover and prioritize this. That you as an employer know that one of the real values of medical care is the kind of continuity of care and the relationships that get built, because those are at the heart of using medical resources wisely and appropriately. And so for you as an employer to say that to the healthcare system and say to the employees, here's what we know will keep you healthy. Here's what we know will keep you happy. It's not just about it's not about productivity. It's about you being healthy and happy.
Which
And
we
that's
know, by the way, for the CFO, if you're listening, CFO, that does actually increase productivity as well. It's not why you do it, but it is a great side benefit and decreases costs and all of the positive benefits we've seen. If I were a employee, what do I go and demand? Like, oh, I want this. What do I say to the head of HR, head of people?
Yeah. What I think you would say as an employee is, I want a health plan where I have access to a doctor who's going to know me. I want a health plan that has access to palliative care so that I can always get my quality of life paid attention to. I want to make sure that this medical plan is going to help me live as well as possible, even if I don't develop a serious illness. Like, I want to live as well as I can.
So in this sort of series of COVID conversations, we have spent beautiful time with Dan Meyer, with
Yeah.
whom you and I are both madly in love. And I know she works with you on Vital Talk a lot, but also with Jen Olson. And she works with the Rosalind Carter Institute and spends a lot of time thinking about how these things play out in big cities, but also how they play out in rural areas.
Yes.
So let's pretend that now I live in a rural area and I can't even find a doctor in the first place, let alone a doctor along the lines of what you're describing. What do I do then?
Yeah. So I think what you do then is, right now in this moment of COVID, I'd be like, I'd be calling the hospital or clinic or calling the insurance company and saying, can't you connect me somebody by Zoom or by phone or virtually? Because there are palliative care doctors and nurses who I know are available, and I want to talk to one of them.
You and I also talked about, you called it pay-as-you-go clinics.
Yeah.
That is this new, and we know there will be more of those in rural areas. What would you say to one of those? And you know the one that I'm thinking about, because I've got big love for Walmart Health. What would you say to them?
Yeah. I would say to a place like Walmart, I would want every part of Walmart where a regular person comes in and is interacting with their health to be coordinated so that when people need something more, that they could get it right there. So that if I come in to pick up my regular meds and I'm chit-chatting with a pharmacist, and then the pharmacist goes, ooh, there's something you should check out, I want that pharmacist to go, hey, can you walk over there and talk to our nurse practitioner for a minute and just have her check this out? Like, what you just told me is something I want to make sure you get covered, right? Like, that's what I would love to see in the kind of easy, coordinated access to healthcare that our country needs.
Yeah. Well, see, I've gotten to spend a bunch of time at Walmart Health, which is these new clinics. And that's, they don't only do that, but they also actually take you by the hand because you came in ostensibly because your tooth was aching. But in the course of that conversation, they realize that you actually have a behavioral health issue.
Yeah.
Or really what's going on is some kind of a diabetes related condition. And they'll actually walk you over not just to the pharmacist, but also to these other really holistic components of care. That is what old-fashioned medicine was all about, which is what you are reminding us we need to go back to.
Yeah, I mean, we need to rebuild that old-fashioned sense of, you see one person and they go, oh, let's take you over here and do the warm handoff and help you get the care you need. And I think what we're dealing with now is, there's just a much greater level of complexity. So it actually takes more infrastructure and better planning and more organization to be able to do what in the old days seemed effortless, right? And I think that's what that's what we're all trying to build right now, right?
Well, and this is a case where it might be that in the running smack into the wall as a healthcare system, into uh, uh, you know, an environment that was designed only to care for you once you were sick. We
Right.
might actually be able to unravel that so we can get out into all corners of communities with this broader definition of what health is, with a broader feeling for what the tools are that we can bring to bear, which include having conversations about what matters to you and
That-
making sure that those are across all aspects of care. And I love how hard you're doing that. I'm so grateful. So I want to ask you two last quick questions.
Sure.
The first one is, what is something that people would be really surprised to know about you? I'll go first, which is you're actually an excellent a popsicle distributor. But in addition to that, what else would be something that folks don't know?
Yeah, something that well, you know what my work in how do you guide people to do things, it's gotten me really interested in maps. And so now I have become like a map collector and map reader of all kinds, but because it turns out even before, GPS was invented, there were people who were really thinking about how do we show people how to get somewhere else, right? And it turns out that is totally fascinating. So that's one thing.
So we didn't talk about this before. I actually am obsessed with maps, and I no longer use a GPS because I found that I no longer had a sense of where I was in the world.
Yes.
And I felt lost. And when you actually look at a map and you realize, oh, I'm here and this is there and we'll go here, and it gives you a sense of self-efficacy that you can get someplace if you don't have access to your GPS. And they're showing that certain parts of our brain are shutting down when all we use is GPS
Oh,
because we're not exercising this spatial component of our brain, which I think has huge correlations to what you're talking about. Because
yeah.
these conversations that we have as humans, we're creating these maps for each other of who we are and where we are and what we care about and who you are and what you
That's
care
right.
about and how we all
And
interact with each other.
and every time we have one of those conversations, it's like building that little muscle that says, I can talk about what I really care about my health, and someone will listen, right? Like, the maps, like, the London cabbies, they have a part of their brain that's bigger than regular people because they have stored so much spatial information about how to get around town. And I feel like we need to do the same thing with ourselves. We need to grow that little muscle and that little part of our brain about how could how can we talk about our health and how to stay healthy in a way that everyone will know what we want, from the pharmacist to our neighbor to our uh, sister. Like, how do we start to do that so that it's not about just shaming people into doing things about their health, but about all of us encouraging each other to
Yeah.
live in healthier ways.
Well, and it's interesting because I would take, when you say, how do we talk about our health? It's actually, how do we talk about our life? Because
And our
that is
wellness.
actually, right? Health is life. And I think we say a lot, shame is just a conversation waiting to be had. And that's exactly what you're alluding to.
That's right.
So what's the one thing, give us a call to action. What is the one thing you want each of us to do immediately, as in literally right now?
Yeah. So right now, in the age of COVID, I want you to think about, if you had a complicated health situation and someone else needed to speak for you for whatever reason, do you know who that is, and do they know? So you should pick out who that person is in your head and make sure they know that they're the one. That would be the one thing.
And when you do that, also recognize what an honor it is you're giving to that person that you're telling them,
I
right?
know.
Because you can make
Well,
that a celebration, a
I
beautiful conversation.
I think that's such an important thing, because we've constructed this legal liability thing and this legal document, and actually what we're saying to someone else is that I love you and trust you.
I honor you.
Right?
That's exactly right.
I honor you, and the reason I do this is because I love you and I know that you will be there for me. Right?
Yeah.
Like, how much more of an honor could that there be, right? And we have to start treating it like that. You're so right.
Well, just like you ask someone to be godparent to your kids, right? That's, we
Yeah.
call it an archangel. Like, will you be my archangel? Will you care for me? Which is a
That's right.
beautiful concept, and it flips it
Yeah.
in a way that is about the honor as opposed to the other
And
aspect.
I think many people are so worried about burdening, the other person, like, because it's not what we do in our society right now. But actually, I have never seen someone react by saying, no, I don't want to do that. They're like, oh, really, me? Right?
I think that's
It's
so
so interesting.
true. And it's a freedom of burden, because then you know what your role will be and what you can do.
That's right.
Thank you. Where can people go? Tell me quickly, where can they go to learn more about Vital Talk and these tools?
Yeah, they can go to vitaltalk.org, vitaltalk, all one word, .org, and they can hear more about what we're doing with doctors and patients. And if you go to the CAPC website, capc.org, you can actually see a video of me talking to lay people or caregivers about things to do, a couple that we just referred to.
And getpalliativecare.org, I think, also has those
Yes,
links too.
getpalliativecare.org also has that. Thank you for reminding me.
Yeah. Tony,
Yeah.
I love you madly. Thank you. Thank
I
you. Thank
love
you.
you too.
Truly, you're extraordinary.
Thank you for doing
So
this
grateful.
work and putting this out into the world. It's so important. Thank you.